to dignitaries, faculty members and colleagues. Today we have gathered here to discuss on ophthalmic manifestations in systemic diseases. I, Dr. Somya Sharma, Assistant Professor in Department of Ophthalmology under guidance of Head of Department and Professor Dr. Chaitanya Prakash Gupta, will be presenting on introduction and brief anatomy. So first, coming to the history, Hippocrates first noted that eye is the mirror of the body. He implied that statement when he noticed yellowing of sclera due to jaundice. This was an early recognition of the eye reflecting systemic metabolic states. Now coming to the brief anatomy of the eye. The eyeball sits in a bony socket called as orbit. It consists of three coats. The outermost is the fibrous coat, which comprises of anterior 1/6 transparent structure known as cornea and posterior 5/6 opaque white structure known as sclera. The middle is the vascular coat known as uvea. It comprises of iris, which is the colored part of the eye, and it regulates the amount of the light entering the eye through the sides of the pupil. Ciliary body consists of ciliary muscles and ciliary epithelium, and the posterior part is the choroid, which consists of a bundle of blood vessels. The innermost part is the neural part, which comprises of retina and optic nerve. Retina consists of specialized cells known as photoreceptors along with retinal pigment epithelium. Optic nerve is the second cranial nerve of the body, and it carries visual sensations from eye to the occipital cortex in the brain through a specialized pathway known as visual pathway. Now, eye is divided into two segments, anterior and posterior segment, by a refractile biconvex transparent structure known as lens. The structures which are anterior to the lens comprises the anterior segment and consists of cornea, iris, aqueous humor and lens. And the structures which are posterior to the lens comprises of the posterior segment, and it consists of vitreous humor, choroid, retina and optic nerve. Now coming to the various connections that eye has to the whole body. First is the vascular connection. Retina is supplied by central retinal artery and vein, which are part of body circulatory system. So any diseases affecting this circulatory system can be manifested in eye as well. For example, diabetes may cause diabetic retinopathy, hypertension may cause hypertensive retinopathy. Next, inflammatory responses. Eye is sensitive to autoimmune diseases like rheumatoid arthritis, Sjogren's syndrome, systemic lupus erythematosus. Immune system can attack this ocular tissue, causing dry eyes, uveitis, scleritis. Next is the neurological link. Optic nerve connects eye directly to the brain. So any systemic neurological condition such as multiple sclerosis can cause optic neuritis, or raised intracranial tension from conditions like pseudotumor cerebral can be identified by detailed eye examination. Next is metabolic and endocrine effect. Diseases such as diabetes mellitus and thyroid disorder can have direct ocular impact and thus can cause characteristic ocular features. Infectious diseases. There are various systemic infectious diseases which can affect the eye and can be diagnosed early by detailed ocular examination. For example, it is presumed that latent tuberculosis can be diagnosed early if we see in eye manifestations such as choroid tuberculosis. Next, to proceed further, I would like to call Dr. Rimsha, who will be discussing on ophthalmic manifestations in diabetes mellitus.
Good morning everyone, I am Dr. Rimsha Zakariya and I shall be continuing further on the topic ophthalmic manifestations in diabetes mellitus. Discussing it via a case, a patient Mr. T, 56-year-old male, came to the IOPD with the chief complaints of gradual painless diminution of vision in both the eyes for last 6 months. He was a known case of type 2 diabetes mellitus for last 12 years and was on irregular medications. His current HbA1c was 10 and BP at presentation was 118 by 82 millimeters of mercury. On ocular examination, visual acuity was 6 by 36 in both the eyes. Intraocular pressure and pupil were both within normal limits in both the eyes. Slit lamp examination showed posterior subcapsular cataract, and on fundus we could see dot blot hemorrhages, hard exudates and macular edema. So would any one of you like to guess what the diagnosis could be? Why?
Since he is a diabetic, prolonged diabetic patient, and there is macular edema. Macular edema comes in advanced diabetic retinopathy, and there is a progressive painless loss of vision. So this history signifies non-proliferative.
Thank you. Yes, you are right. So we diagnosed the patient with uncontrolled diabetes mellitus, both eyes posterior subcapsular cataract, and moderate non-proliferative diabetic retinopathy with diabetic macular edema. Moving forward to the ophthalmic manifestations in diabetes mellitus. Now eyelids show recurrent blepharitis, styes, and styes also known as external hordeolum and chalazion. In cornea, we can see neurotropic keratitis, which presents as superficial punctate keratitis, seen on fluorescein staining on the slit lamp examination. Now, neurotropic keratitis is a degenerative disease caused by impaired corneal nerve supply, mostly affecting the trigeminal nerve. It can further progress to neuropathic corneal ulcer and eventually to even perforated corneal ulcer. Next, we could see neovascularization of the iris. Now, this is known as rubeosis iridis. In lens, the two common cataracts that are seen are snowflake cataract and posterior subcapsular cataract, where snowflake cataract is the most characteristic one. However, posterior subcapsular cataract is the most common one. Here in this image, we can see vitreous hemorrhage, which is blood in the vitreous due to leakage of vessels caused by neovascularization of in diabetes. On retina, we see various changes due to chronic hyperglycemia mediated microvascular damage in the retina. And the retinopathic changes seen are as follows. First is this microaneurysms, which are seen due to pericyte loss. Second that could be seen is dot and blot hemorrhages. These are a result of leakage from the weakened capillaries. Then there could be hard exudates and soft exudates. Now, hard exudates are deposition of lipid and protein in the outer plexiform layer of retina. However, cotton wool spots are axonal deposits in the nerve fiber layer of the retina. And lastly, diabetic macular edema. And finally, a retinopathic complication that could be seen is tractional retinal detachment, seen mostly in advanced diabetic eye disease. Moving on to the risk factors of diabetic retinopathy, first one being the duration itself. So, the chance of developing diabetic retinopathy increases to 50% after 10 years and to 90% after 30 years of having diabetes mellitus. The second is poor glycemic control, hypertension, nephropathy, and other risk factors include hyperlipidemia, smoking, obesity, and even anemia. Now, classifying diabetic retinopathy into non-proliferative and proliferative, where non-proliferative diabetic retinopathy is further classified into mild, moderate, and severe. Mild is when only microaneurysms are noted. Moderate when hemorrhages and exudates are seen only in one quadrant. Severe where hemorrhages and exudates can be seen in more than one quadrant or most likely in all the quadrants. Versus proliferative diabetic retinopathy where changes are seen due to neovascularization of retina. So the investigations that we do in such a patient, apart from the routine general investigation on the basis of general etiology, are the ophthalmic ones are fundus photography to classify and study the severity of diabetes mellitus, optical coherence tomography to see diabetic macular edema, and lastly fundus fluorescein angiography to see the leaks. And the most important thing, we tell the patient to have an annual dilated eye examination since it's very essential. Moving on to the next topic, where I shall be discussing ophthalmic manifestations in case of hypertension. A patient, Mr. V, 58-year-old male, was referred to IOPD from medicine ward for fundus examination, and he presented with the chief complaints of headache for last 1 month, which was associated with nausea and epistaxis. He was a known case of hypertension for last 8 years, non-compliant with medication, and his blood pressure at presentation was 180 by 100 millimeters of mercury. On ocular examination, visual acuity was 6 by 12 in right eye and 6 by 9 in the left eye. Intraocular pressure, pupil and slit lamp examination were all within normal limits in both the eyes. However, on fundus we could see arteriolar attenuation, arteriovenous nicking and copper wiring of vessels. Now would anyone like to answer what grading of hypertensive retinopathy it could be, since it involved arteriovenous nicking and copper wiring and arteriolar attenuation? Yes. So we diagnosed the patient with uncontrolled hypertension and grade 2 hypertensive retinopathy. So the ophthalmic manifestations that we could see in hypertension are as follows. First image, we can see subconjunctival hemorrhage. So hypertensive patients mostly very likely come with this complaint. Hyphema, that is collection of blood in the anterior chamber, and vitreous hemorrhage. Now on retina, the signs that are very commonly seen are arteriolar narrowing, copper wiring, arteriolar AV nicking, exudates, which are again hard exudates and soft exudates, dot and blot hemorrhages, and disc edema. Now let's discuss all of these retinopathic changes in a bit detail. Arteriolar attenuation can be of two types, either generalized as we can see in this image, or it can be focal or localized. Now arteriolar attenuation in the first place happens because of a reduced caliber of the arteries. Arteriovenous nicking is due to hardened artery pressing over a vein at the AV crossing, as we can see here. Copper wiring is a red-brown reflex of the arterioles that happens due to sclerosis and hyalinization. This is a macular star which is seen when hard exudates come and accumulate at the posterior pole of the retina. And the last one is disc edema. Now Keith, Wagner and Barker classified hypertensive retinopathy under 4 gradings. First one says that there is mild generalized retinal arteriolar narrowing. Grade 2, which was there in this case that I presented, focal arteriolar narrowing along with arteriovenous nicking and copper wiring. Grade 3 mentions all the grade 2 stage changes along with hemorrhages, which could be dot blot or flame shaped, and cotton wool spots and hard exudates. And lastly, grade 4, where we can see all the grade 3 changes along with optic disc swelling. Next comes the complications of hypertensive retinopathy. It includes retinal artery occlusion, retinal vein occlusion, papilledema, ischemic optic neuropathy, and even Elschnig spots and Siegrist streaks. So lastly, the investigations that we do in such a patient are the general ones depending upon the etiology, which include lipid profile, serum creat, urine examination, and ophthalmic include fundus photography and optical coherence tomography. Now I would like to invite Dr. Ishita to continue further.
Good morning, respected dignitaries, teachers and my dear colleagues. I, Dr. Ishita Rungta, second year resident from the Department of Ophthalmology, will be continuing on the presentation. A patient, Mrs. W, 32-year-old female, was referred from the Department of Endocrinology with the complaints of progressive prominence of both eyes for the past 6 months, double vision when looking up for the past 2 months, and foreign body sensation along with watering and photophobia for 1 month. The patient is a known case of Graves' disease for 2 years on regular medication. She has no prior history of any ocular trauma or surgery. On presentation, her pulse rate was 115 beats per minute. On ocular examination, her visual acuity in both eyes was 612, intraocular pressures were normal, Pupils were round, regular and reactive in both eyes. On measuring proptosis using Hertel's exophthalmometer, it was noted to be 23 millimeters in the right eye and 24 millimeters in the left eye. Positive lid signs in the eyelid were lid retraction, known as Dalrymple sign, lid lag on down gaze, known as Von Graff sign, infrequent blinking, known as Stellwag sign. On extraocular movement examination, there was restriction in elevation. That means that the inferior rectus muscle was involved. Slit lamp examination revealed conjunctival chemosis and mild exposure keratopathy. So what do you think is the diagnosis for this patient?
Graves ophthalmopathy.
You're right. It is Graves ophthalmopathy, also known as thyroid eye disease. So ophthalmic manifestations in Graves disease. There are prominent eyelid signs which are commonly seen as Dalrymple sign, which is lid retraction with scleral show. This is the most common sign. There might be Von Graff sign, which is lid lag on down gaze. Poacher sign, which is a staring, frightened appearance. Stellwag sign, infrequent blinking. And Mobius sign, which is weakness of convergence when looking at a near object. There may be advanced exophthalmos. This is a measurement of more than 25 millimeters, where for reference normal is 21 millimeters. This might lead to a complication of exposure keratopathy that presents as punctate erosions and persistent epithelial defect on slit lamp examination. It also proceeds to a risk of corneal ulceration and eventually perforation. The patient might also present with conjunctival chemosis and superior limbic keratoconjunctivitis. There might be diplopia and extraocular muscle involvement. Restrictive myopathy presents in the order of inferior rectus, medial rectus, superior rectus and lastly lateral rectus involvement. As we can see in this image, the picture on top shows that when the patient is asked to look up, there is restriction in the upward movement of the left eye. This causes vertical diplopia as the inferior rectus muscle is involved. The picture on the bottom represents that when the patient is asked to look towards his right, the left eye does not move with the right eye. This causes horizontal diplopia as the medial rectus muscle is involved. There might also be fibrosis of the extraocular muscles and this might cause concomitant strabismus. In 5 to 8% of the cases, there might be optic nerve involvement which presents as compressive optic neuropathy and is a sight-threatening complication. Investigations we carry out are thyroid function test, autoantibody test. Ophthalmic investigations include MRI orbit. This shows a characteristic fusion belly enlargement with tendon sparing of the extraocular muscles as shown in the image here. We also take fundus photography for optic nerve involvement. Moving on to ophthalmic manifestations in infectious diseases. A patient, Mr. X, 29-year-old male, came to the IOPD as a self-informant with the complaints of recurrent left eye pain, redness and diminution of vision for the past 1 month. He is not a known case of any chronic illness. There is no history of any past trauma or any prior similar episodes. On ocular examination, visual acuity in the right eye was 6.6, while in the left eye it was 6.24. Intraocular pressures were normal. Pupils in the right eye were round, regular and reactive, while in the left eye they were miotic and showed a sluggish reaction. On slit lamp examination, right eye was normal. Left eye showed multiple mutton fat keratic precipitates on the endothelium, an anterior chamber reaction of 3+, and there was presence of posterior synechiae. So what do you think our diagnosis will be?
Granulomatous anterior.
You are right, it is granulomatous anterior uveitis. On sending further investigations, Montauk's test was positive and there were cavitary lesions with consolidation on chest x-ray. So final diagnosis came to tubercular anterior uveitis. Ophthalmic manifestations in tuberculosis. On the conjunctiva, we can see flectinular keratoconjunctivitis as we can see in this image. They present as small, round, pale nodules at the limbus with redness. They represent a type 4 hypersensitivity reaction. Tuberculosis may also present with granulomatous anterior uveitis in which we see mutton fat keratic precipitates seen mostly inferiorly in the arch triangle. There might also be iris nodules. They may present on the pupillary margin known as Kepis nodules or in the iris stroma known as Busaka's nodules. Anterior chamber reaction is considered the hallmark of intraocular inflammation. Cells in the aqueous humor can be visualized as floating particles on slit lamp examination. There might be abnormal adhesions of the iris with the lenticular surface. This is known as formation of posterior synecdoche. This image shows a festooned pupil which is observed during dilatation of a patient. The most common and characteristic ocular presentation is posterior uveitis in tuberculosis. This manifests as choroidal tubercles which are multiple, small and discrete. They are highly specific for miliary tuberculosis. Tuberculosis may also present as a solitary large mass-like lesion known as tuberculoma. Ophthalmic manifestations in leprosy. Leprosy may present as iris pearls. This is a pathognomic finding of lepromatous leprosy. There might be madarosis, which is loss of lashes and lateral half of the eyebrows. In tuberculoid leprosy, there is involvement of the facial nerve and the ophthalmic division of the trigeminal nerve. This leads to incomplete eye closure known as lagophthalmos that we can see in this image. And there might be chronic uveitis, which is the most frequent ocular manifestation of leprosy. Ophthalmic manifestations in herpes zoster ophthalmicus. Hutchinson's sign is defined as vesicular lesions at the tip, root and side of the nose. It is a strong predictor for ocular inflammation and corneal denervation in herpes zoster ophthalmicus. On slit lamp examination, we may find keratic dendritic ulcers on fluorescein staining, iris atrophic patches, and many serious cases might progress to retinal vasculitis, which may cause necrosis of the retina. A late consequence of herpes zoster ophthalmicus is Ramsay-Hunt syndrome. It presents with facial palsy, due to which the seventh nerve is involved. This causes lagophthalmos and exposure keratitis. Ophthalmic manifestations in toxoplasmosis. The most common cause of infectious retinochoroiditis is toxoplasmosis. It presents as a white focal retinitis with overlying vitreous inflammation. This gives the appearance of a headlight and fog. Ophthalmic manifestations in human immunodeficiency virus. Microangiopathy is the most common ophthalmic manifestation in HIV. This presents as cotton wool spots. It signifies an advanced HIV disease, higher levels of ongoing viral replication and low CD4 plus T cell counts. Ophthalmic manifestations of cytomegalovirus. A classic fundoscopic finding includes confluent areas of retinal whitening with hemorrhages. This is known as pizza pie retinopathy. Cytomegalovirus is the most common opportunistic ocular pathogen in advanced HIV disease, typically occurring when CD4 plus T cell count falls below 50 cells per milliliter. Finally, discussing dengue, the most common hemorrhagic complication presents as premacular hemorrhage, and the most common maculopathy in dengue seen is macular edema. So investigations done are general investigations which are specific according to the infectious etiology, and ophthalmic investigations include optical coherence tomography and fundus photography.
Signs were of dryness, redness, diminution of vision in both eyes since last 2 months. Symptoms were progressively worsening with occasional pain and discomfort. She was a known case of Sjogren's syndrome since last 3 months and was on regular medication. There were no other history of chronic illnesses. On ocular examination, the visual acuity was 6/9 in both the eyes. Intraocular pressures were within normal limits and pupils were round, regular and reactive. TFM assessment test was done and less than 5 mm in 5 minutes in both the eyes was recorded on Sharma's test. Less than 5 seconds was noted on tear film breakup time, and on fluorescein staining, superficial corneal staining was seen. The anterior chamber and fundus examination were within normal limits. So I'd like to ask the audience if they can guess the diagnosis.
Severe dry eye disease.
Yes, you are right. The diagnosis of severe dry eye disease in both the eyes consistent with keratoconjunctivitis, SICA, was made due to the underlying Sjogren's syndrome. The ophthalmic manifestation seen in Sjogren's syndrome. As we can see here, the small scattered spots of epithelial damage due to corneal epithelium inflammation secondary to dryness is known as superficial punctate keratitis, consisted with keratoconjunctivitis SICA. Filamentary keratitis is another ophthalmic manifestation seen in which strands of degenerated epithelium and mucus are adherent to the corneal epithelium and can be seen in severe dry eye disease. Meibomian gland dysfunction. These are modified sebaceous gland in Sjogren's syndrome. Due to chronic ocular surface inflammation, the damage to meibomian gland happens leading to meibomian gland dysfunction and further deteriorating the severe dry eye disease. Ophthalmic manifestation in other connective tissue disorder like rheumatoid arthritis. In conjunctiva, we see the keratoconjunctivitis sicca. In the cornea, we see the peripheral ulcerative keratitis. Here, the corneal stroma melts near the limbus associated with the systemic vasculitis. In the sclera, immune complex mediated vasculitis affecting the episcleral and deep scleral vessels, leading to a benign condition, episcleritis, in which there is mild tenderness and superficial vessel congestion, sectoral redness and no scleral thinning. Whereas in scleritis, there is severe boring pain radiating to temple and jaw with a deep violaceous hue due to scleral thinning. In the uvea, we see anterior uveitis. It is an autoimmune mediated destruction of the uveal tissue which causes anterior uveitis. Here, on slit lamp examination, we see posterior synechial formation, iris pigment dispersal and irregular pupil, whereas we also see keratitic precipitates, which are aggregates of inflammatory cells on the corneal endothelium. In the retina, we see the retinal vasculitis, which is inflammation of the blood vessel walls in the retina, which can lead to vision loss. The ophthalmic manifestation is systemic lupus erythematosus. Here we see red erythematous plaque-like lesion seen over the eyelids known as discoid lupus lesion. And in the cornea, we see punctate epithelial keratitis. We also see peripheral ulcerative keratitis in which the corneal stroma melts near the limbus. In sclera, we see the scleritis. Due to the scleral thinning, we see this violaceous hue. And in the retina, we see personal-like retinopathy along with optic neuropathy. The investigations for connective tissue disorders are general investigations and ophthalmic investigations. The ophthalmic investigations are Sharma's test, tear film breakup time, fluorescein staining, which are for the dry eye disease, fundus photography, optical coherence tomography, and fundus fluorescein angiography for the retinopathy. Now I will be discussing some specific ophthalmic manifestations seen in systemic diseases like myasthenia gravis. We see ptosis and extraocular muscle paralysis. In hypolipidemia, we see xanthelasma. In hematological diseases like anemia, we see retinal hemorrhages, rod spots and cotton wool spots. In leukemia and lymphoma, we see retinitis and optic nerve inflammation. In albinism, we see myopia, astigmatism and nystagmus. Down syndrome, the ophthalmic manifestation is mongoloid slant and epicanthal fold. In von Hippel-Lindau syndrome, in retina, we see the retinal capillary hemangioma. In Wilson disease, we see Kayser-Fisher rings. Alport syndrome, we see anterior lenticonus. Marfan syndrome, myopia, dislocated lens and retinal detachment. Neurofibromatosis type 1, we see leash nodules on iris and optic glioma. Now I'd like to call Dr. Anush Jain to further continue the case presentation.
Good morning everyone. I am Dr. Anush Jain, Senior Resident in the Department of Neurology. I would like to discuss the ophthalmic manifestation in neurological diseases. I would like to begin with a case scenario. So there is a patient, Mrs. Z, 26-year-old female, graphic designer by occupation, came with chief complaints of left eye diminution of vision for 4 days associated with pain on eye movements. There is no history of any systemic illness, no history of trauma or prior such episodes. On ocular examination, visual acuity was 6/6 in the right eye and 6/36 in the left eye. Intraocular pressure was 11 mm Hg in the right eye and 15 mm Hg in the left eye. Pupils were round, reactive and regular in right eye, but there was relative afferent pupillary defect in left eye. Color vision, she was able to read all 38 plates from right eye and she was only able to read 2 plates from left eye. Visual field was normal in right eye while there was central scotoma on the left eye. On fundus examination, right eye was normal. Left eye, the optic disc was hyperemic with blurred margin with dilated surface capillaries. Would anyone like to volunteer and tell the diagnosis? Yes, it is left eye papillitis, that is optic neuritis. So on further investigation, MRI was done, which was suggestive of optic nerve enhancement with periventricular lesions. VP was done, which was suggestive of UV 300 from left eye. CSF oligoclonal bands were present. Autoimmune panel and serology were negative. So the diagnosis was optic neuritis secondary to clinically isolated syndrome of multiple sclerosis. So management and outcome, patient was given steroid pulse therapy followed by oral taper and was started on interferon beta 1A, and vision improved to 6/18 of left eye at 2 weeks from onset of symptoms. Now coming to papilledema versus papillitis. In papilledema, usually vision is initially normal. In papillitis, there is decreased vision. Pain is usually absent in papilledema, while papillitis is painful. Onset is gradual in papilledema, while in papillitis it is sudden. Pupillary reactions usually normal in papilledema, while in papillitis there can be relative apparent pupillary defect. Fundus examination, bilateral disc swelling with blurred margins, venous engorgement and flame hemorrhages can be seen in papilledema, while in papillitis, hyperemia, blurred margins, sometimes peripapillary hemorrhages can be seen. So, common causes of papilledema are intracranial tumors, intracerebral hemorrhages, idiopathic intracranial hypertension, cerebral venous sinus thrombosis, malignant hypertension and vitamin A toxicity. Common causes of papillitis are multiple sclerosis, neuromyelitis optica spectrum disorder, infections like herpes simplex, varicella zoster virus and tuberculosis, leukemic or lymphomatous infiltration, and drugs like ethambutol. Coming to visual field defects, so depending on the site of lesion in the visual pathway, field defects can be total right eye visual loss as depicted by the first lesion, or there can be bitemporal hemianopia or left nasal hemianopia depending if there is the involvement of optic chiasm. Right homonymous hemianopia can be there if there is involvement of left optic tract, and left homonymous hemianopia with macular sparing if there is involvement of right occipital cortex. Coming to common etiologies of visual field defects, if optic nerve is involved, it can be secondary to optic neuritis or NAION, secondary to diabetes or hypertension. Optic chiasmal involvement can be seen in pituitary adenoma, craniopharyngioma, or anterior-communicating artery aneurysm. Optic tract can be involved in stroke or demyelination. Lateral geniculate nucleus can be involved in thalamic infarcts. Optic radiation, if involved in temporal lobe, will cause superior quadrant anopia, while in optic radiation involved in parietal lobe will cause inferior quadrant anopia, and lastly occipital cortex can be involved in PGCR. So to take the session further, I would like to invite Dr. Somya.
So after all this discussion, now what can we conclude? That eyes don't lie, as they provide important systemic clues in ocular practice. There are many ocular signs which reflect underlying systemic diseases. Early recognition of these subtle signs, proper history taking and detailed ocular examination can prevent in missed or delayed diagnosis. It helps in identifying which subspecialty to refer to for further evaluation and timely management of the patient. This enhanced interdisciplinary collaboration, which is possible only in a multi-specialty setting, helps in working in best interest of patient's health and well-being. And finally, knowledge is not just power, it's only potential. Applying that knowledge is power. Understanding why and when to apply that knowledge is wisdom.